Very good. Good morning. My name is Ryan Garrett, and I'm one of the fellows in EMS medicine at University of Cincinnati, one of the emergency medicine physicians. And I'm here this morning on behalf of the Southwest Ohio Academy of Medicine to talk to you about a new protocol that's going to be live in 2015 on tranexamic acid. There's a variety of new protocols that are going to be coming down the pipe this year for the new year, but this is specifically a new medication, new to this region, at least for ground EMS. And so we felt like it would be appropriate to film a video. This is be about a 45 minute video designed to be used for drill, station drill, addressing the protocol, addressing the medication, why we use it, what's kind of the literature behind it, etc. And then we'll do a 10-minute video or so that just specifically hits the nuts and bolts of the protocol. So I'm involved with a variety of different fire departments. I'm a former EMT prior to going to medical school, involved with Cincinnati Fire, Colerain, Air Care, a variety of places. So real quick, a huge thank yous to a lot of different people. Thank you to Springfield Township for having me out and filming this and putting the production together for the region. A variety of people went into making this happen. A new medication for trauma patients involves a lot of different people. UCMC Division of Trauma was absolutely instrumental in making this happen and revising this and making sure that what we do in the field benefits the patient and kind of the continuum of care for these critically ill trauma patients. Dr. Robinson, Dr. Muscat, Dr. J. Johanneman, certainly clinical pharmacy was involved. Dr. Mel Otten, certainly a legend in this region, and many of you know him, was also instrumental. Dr. Bill Hinckley, Air Care and Mobile Care were huge. We started TXA in this region first with Air Care and Mobile Care probably about a year ago now. And so having worked through that process, learned a lot along the way about the kind of implementation of this and how we need to do this. Life Flight of Maine, thank you to them. They're a helicopter service that kind of covers the northeast of the U.S., and they were instrumental. They were really the first ones that kind of made this possible for helicopter EMS. And then Dr. Jeffrey Goodlow is really, I think, probably credited for being the mastermind of ground EMS having TXA. He started in Oklahoma City and Tulsa Fire, has presented on this nationally, and it's really kind of their work pioneering this from the military now into the civilian ground EMS, and so we owe them many thanks, and he has answered my questions, many of them along the way, so thank you to him. So I have absolutely no disclosures whatsoever. I am an emergency physician who about a year and a half ago started reading about tranexamic acid and some of the military studies were using it in the hospital. And I said, this is really a medication that we're starting to look at for EMS, and so I kind of champion that movement, both on the air and ground side for Southwest Ohio. I have absolutely no disclosures. So what are we going to talk about? Briefly, we're going to talk about body's response to trauma. So kind of starting at the basics of when you are out on Ronald Reagan, or when you're out on 75, 275, somebody's critically injured, that time zero, what happens in that motor vehicle collision, that motorcycle crash with the body's response to trauma? Somebody's shot in the chest, assaulted with a bat, what happens immediately at time zero and progresses kind of in the next 30 minutes, hours progressively in response to that trauma? It's complicated, and it's absolutely instrumental to how we treat the trauma patient. We're going to cover that in about 2 slides. We'll hit the nuts and bolts. Talk about what is TXA. Is it a new medication? Is it an old medication? I think I've heard of it before. We'll talk about it specifically, a little bit of its history, how it applies to EMS. How does it work? This is important. Anytime we give a medication in EMS and anytime we give a medication in medicine, period, we should understand how it is that it's working, how we're interplaying with the patient. That's really what separates us in terms of kind of good and adequate following protocols and taking it to the next level and really exceeding and excelling in patient care. We'll go a brief review of the evidence. I'm absolutely not going to bore anybody with kind of the stats and the nuts and the bolts, but there are a couple of big trials that we should all be aware of, because you are going to be asked about this. When we started using it with Air Care and Mobile Care, I immediately started getting emails from all over the country. How are you doing it? What's the support? What's your protocol? When we roll this out as a region, there are going to be people locally, nationally, that are going to look at this, maybe the Dayton area, maybe down in Kentucky. And so your colleagues around the country and in this profession are going to ask you, you're doing TXA, I've read about it, tell me about it, how does this work? And so we're going to give you a little bit of the evidence to kind of help support that. Use of TXA and EMS will specifically kind of show what's being done nationally. I think it's important for everybody to understand, our patients to understand, for the agencies to understand that we're certainly not the first in the nation to be doing this, but we're on the cutting edge, and that's exactly where we like to be. That's exactly the aim and the goal of the Southwest Ohio Protocol Committee, is to really bring the cutting edge medicine to our patients in this region. We'll go over the Southwest Ohio Protocol. That'll be really the nuts and the bolts of actually at 3 in the morning on the side of the road, how do you give it, when do you give it? That's the really, truly nuts and bolts. And so I'm going to rely on all of you in this room to really ask those questions that you want to know. I've given this presentation several times. I think I've fielded a ton of questions on this over the last year or so, so I think I probably have the answers to most questions, but please ask those questions. And then where do we go from here? There is some research to be done. There are some question marks, I'll be honest with you. We know a lot about TXA, but we certainly don't know everything. And so this is absolutely a medication that I think we have a protocol for now. It's going to go live in January, but this is probably a medication that we are going to expand in the future in terms of who we give it to and how we do it, because there's some question marks, and that's okay. That's exactly where we want to be. So that's our objectives for the next 40 minutes or so. All right, so you can't really talk about trauma until you talk about, and you have to start in trauma talking about the lethal triad. And so some maybe in the audience and looking at this and viewing this in their own station houses may have heard about this. Certainly if you've been to a lecture on trauma that I've given, you've heard about this. This is typically how I start all trauma lectures, and it's very important to understand this. The lethal triad was a term coined in the roughly early 1980s. It kind of came out of the surgical literature, and basically a bunch of physicians were saying, you know what, we've got these really sick surgical patients. We go in, we fix the problem, but then hours and days later, they still continue to get worse. They continue to have all of these kind of physiologic abnormalities, and they die. And one surgeon coined the term of this kind of lethal triad, this bloody vicious cycle. And that's actually kind of coming out of the original paper that described this. And so what we originally decided, or what we kind of originally discovered, whether it be surgery or trauma, it's all the same thing. It's damage to the body, damage to the tissue. This cascade, this kind of triangle starts. And it starts with tissue damage, it starts with bleeding, and as you bleed and as you have more tissue damage from whatever reason, gunshot to the chest, ruptured spleen from a motorcycle crash, doesn't matter, fall from a ladder, injury to the body, bleeding inside or outside, doesn't matter, your body will start to head towards this triangle of death, this lethal triad. It's got 3 points, that's why it's a triad. Hypothermia, so low body temperature, acidosis, and coagulopathy. And that didn't print well, my apologies, but coagulopathy is a term basically for your body doesn't make clot the way it should. Anytime you bleed, skin your knee, rupture your liver, have surgery, your body starts a process of making clot, and coagulopathy is the body's inability to make that clot. You start to just bleed more. Now, the issue with the lethal triad is there's a couple of things. We don't know when exactly it's starting until it's there, and it's a self-propagating cycle. So, patient becomes hypothermic. Let's say right now, I was driving in, it's pouring rain outside, motor vehicle collision on 275 that delayed me getting here a little bit. It's about 60 degrees out, it's pouring rain. You guys are doing the extrication on that patient. That patient has absolutely already started the process towards hypothermia. It's summertime, it's August, but they're wet, it's 60 degrees out, and they're bleeding internally. They are absolutely headed towards hypothermia. As you get more hypothermic, you become more acidotic. As you become more acidotic, the hormones and the chemicals, the proteins in your body don't work as well. Epinephrine, adrenaline, all the hormones you need for kind of life and survival don't work as well. As you become more acidotic, you become more coagulopathic. You don't make clot as well. As you don't make clot, you bleed more. You start having more hypothermia. You start having more acidosis, and the cycle goes round and around and around. And so this is the critical, these are the all trauma interventions, trauma care really centers around this slide and understanding and preventing the lethal triad. There are things that we do in EMS that can help the lethal triad or prevent the lethal triad. There are things that we do that can worsen the lethal triad. So let's say you have a patient with a blood pressure of, 80 systolic, and you put 2 or 3 or 4 liters of crystalloid in them. Normal saline is an acidotic fluid. That's why the protocols are written that, if they have a normal mental status, they have a palpable pulse, we like that idea of hypotensive resuscitation. That's a term that you've probably heard. Or damage control resuscitation. Those are terms where we try and limit crystalloid infusion. If their mental status is okay, they have a pulse, we try and limit the amount of crystalloid because it dilutes things. It makes your coagulopathy worse. It can make you hypothermic. You think about a bag of normal saline in your truck. It's what, 70, 80 degrees roughly, sitting in the bay, 70, 80 degrees. That's actually hypothermic. Your body temperature is 97. It's actually hypothermic crystalloid. It's actually acidotic. So I bring this up because TXA directly targets this. This is the core and kind of the beginning of all trauma resuscitation. Second slide on response to trauma. This is an important slide. And it's important. It's a little bit busy. Understanding all of this is not necessarily the key thing. I put that up there really just more to demonstrate kind of the complexity of the patients we're talking about and we're dealing with. So trauma, any sort of trauma, initially results in the formation of clots and the stimulation of clot breakdown. So you skin your knee, gunshot to the chest, rupture your liver, broken femur, doesn't matter. Your body starts this balance beam of process of I need to make clot to stop bleeding. That's good. But at the same time, your body wants to maintain homeostasis. So it recognizes, just like anything, that if I'm making clot, I don't want to make too much clot. I want to keep everything balanced. And so we'll start actually breaking down clot. And that's okay. That's normal. That is how we heal. It's well understood. It's just part of the body. The issue becomes, and the term for clot breakdown is fibrinolysis. So fibrin meaning clot, lysis meaning breakdown. The issue becomes is sometimes in trauma, the fibrinolysis can become too extreme. It can become out of whack. And that homeostasis, that very careful balance beam of I need to make clot and I need to break down clot begins to tip. And so in trauma, in the critically ill patient, you can sometimes have a phenomenon called hyperfibrinolysis, meaning too extreme or too much breakdown of that clot. And if you're bleeding from your liver, or you're bleeding from your chest, or you're bleeding in your brain, if you start to have too much hyperfibrinolysis, you're not making clot and you are going to bleed more. And going back to the original slide, more bleeding equals more hypothermia, equals more acidosis, equals more coagulopathy, and you can see we very quickly spiral out of control. So the breakdown of clot by your body, hyperfibrinolysis, results in increased hemorrhage. And you can see kind of here just this complex kind of interaction of all of the things that go into the bleeding trauma patient, coagulopathy of trauma. But that's a key fundamental point there is you're injured, your body wants to make clot, it also wants to break down clot. If you break down too much clot, you bleed more. So what is TXA? It's an old medication. It's been around since 1986. It's FDA approved for a variety of reasons. It was originally approved for hemophiliacs undergoing tooth extraction, so patients that are missing, factor 8 or factor 9, they would have tooth extractions, for dental cavities or whatnot, and they would bleed excessively, so TXA was used there. It's actually used for abnormal uterine bleeding. That's a very common indication of it in a pill form. We're going to be using an IV form, but in a pill form. It's been around for quite a while. It's been used in elective cardiothoracic surgery. Again, all of this idea of patients are bleeding and we want to help them stop bleeding. So how does TXA do that? It's an antifibrinolytic. So I said fibrinolysis was fibrin clot, lysis breakdown. Anti means just stopping it. So it's stopping that clot breakdown. It does it by a couple of mechanisms. It's a competitive inhibitor of plasminogen activation, plasmin activity. So essentially prevents clot breakdown and thus reduces hemorrhage. But again, the important thing to know is that it's an old medication. This is not some, kind of experimental thing straight off the lab that we're not really sure. We've been using this medication for a long time. It's just in the last about 4 years or so that it's had an exciting new future that's applicable to EMS. So since 2010, the future of TXA has absolutely changed. And these are the two studies that we need to know about, that we need to talk about, at least just a little bit. There are certainly people, my bosses and folks that I work with in University of Cincinnati that have kind of gone over this literature in detail and really nitpicked this. But I'm going to show you kind of some of the key take-home points of these two trials that really brought TXA to EMS, brought TXA to trauma patients in and out of the hospital. So CRASH 2 was 247 hospitals across 40 countries. That's huge. I mean, when we're talking about doing research, I mean, we get excited about, a couple of hospitals involved, a couple of centers. I mean, 40 countries. 247 hospitals. It was a randomized placebo-controlled trial. So in other words, some patients got TXA, some people got saline, and it was randomized. So you didn't really know who was getting who. We like that when we're doing scientific research. 20,000 patients. That's a lot of patients. I mean, we're talking, you look at a lot of studies that we make decisions off of in medicine, they've got a few hundred or a few thousand patients. This is 20,000 patients with or at risk serious bleeding based on vital signs. This is all they used. They said, you know what? They have got a serious injury or potential for a serious injury. They crashed their car. They fell off the roof of their house. Their heart rate was greater than 110. Their systolic blood pressure was less than 90. They got 1 gram of TXA over 10 minutes, and then they got a gram of TXA over the next 8 hours. That's what they did. Here's what they showed. At the end of the day, all-cause mortality in those that got TXA was decreased by 10%. The risk of death from bleeding was decreased by 15%. And the signal for benefit in TXA was actually strongest the more sick you were. So if you were bleeding out on the side of the road and your pressure was less than 75, it was, let's say 60 systolic, it's actually even the sickest of the sick trauma patients that seem to benefit most from this medication. And interestingly enough, and I bring this up only because it's talked about and you may get questions about this, in CRASH 2 it did not reduce the need for blood or surgery. Wait a second. So you just told me, Doc, that this stops clot breakdown, supposed to stop hemorrhage, and in this big trial you're telling me it didn't stop the need for blood replacements and stuff like that. That doesn't really make a lot of sense. You're right. That draws us to some questions. So you think no statistical difference in this trial for who got blood or needed blood. You would think if it stopped bleeding in the patients that got TXA, then they probably wouldn't need as many blood transfusions. That makes sense. So a lot of smart people, much smarter than I am, that are doing this research in real time, think that, you know what, TXA does stop clot breakdown, does stop hemorrhage, but maybe it has a different effect. Maybe there are some other things that TXA does. And kind of one of the leading thoughts is that maybe some of the mortality benefit of TXA actually lies in in decreasing inflammation to trauma. So you get critically injured, your body, I showed you in slide number 2, kind of that complex interaction of processes that are going on. There's inflammation, wound damage, that maybe TXA has a role in that. Either way, we're excited about this because a medication that has multiple mechanisms may have multiple applications, and that's an exciting future for this medication. So there are some question marks. At the end of the day, it showed decreased mortality, and that's obviously a very good thing. All right, so that led to the World Health Organization actually adding it to its list of essential medications, and that's a big deal. So the World Health Organization kind of says, you know what, these are the list of medications that hospitals, that organizations need to stock kind of these essential medications. And they said on the basis of the results of a very large trial, the use of TXA, specifically in trauma patients, including those who have been in road traffic accidents, the committee concluded there is sufficient evidence to support the proposal that listing TXA may contribute to a reduction in this cause of death. And so that's a big deal from the World Health Organization. Now, the second trial that we need to talk about, this was going on roughly at the same time. Crash 2 was all done overseas. It was those 40 countries were all overseas. This was actually done in the British military in southern Afghanistan. And these patients in MATTERS, this is MATTERS trial, were very sick patients. I mean, these were truly, badly injured military personnel, road blasts, gunshot wounds, etc. It was a retrospective study, so they looked back in time on these patients. It looked at about 900 combat casualties requiring at least one unit of blood, essentially. So these were very sick patients that needed blood. Look, it was in the surgical hospitals in southern Afghanistan. What they showed was that a TXA group had a decreased mortality, 17.4% from 23.4%. And this was despite the patients who got TXA having a worse ISS. ISS is injury severity score. So basically you bring in a trauma patient, we kind of do some math and figure out exactly how bad they're injured, and ISS is, think of it kind of like a GCS. It's a standardized scale that allows us to kind of communicate. They had an ISS of 13. I know how injured that person is versus an ISS of 20. So the patients in this study that got TXA were more injured. They should die more. They should do more poorly. They were more severely injured. But those that got TXA actually did better. Had an increased benefit in patients receiving massive transfusion. So again, I showed you in that previous study where the more sick the patient was in Crash 2, the better they did if they got TXA. Same thing here. The more blood products the patient needed, the more sick the patient was from trauma, the better they did if they got TXA. Pretty significantly so. I mean, a mortality of 14.4% if you got TXA versus 28% without TXA, that's a big deal. That raises a lot of attention. And then TXA was independently associated with survival and less coagulopathy, less bleeding in MATTERS. So 67. 67 is the number needed to treat. So number needed to treat is a statistical term for essentially how many times do you need to give a medication or do an intervention to prevent one bad outcome. Okay, that's just a kind of standard statistical term we use, and it helps a lot, right? So the ideal medication for anything, any therapy in all of medicine, is a number needed to treat of 1, right? That's the perfect intervention. So if I give this special pill or medication to one person, it 100% of the time prevents bad outcomes. Very rarely, there's very few things, if anything, that I can think of that has a number needed to treat of 1. That's very rare. 67 was the number needed to treat in the Crash 2 trial. So in other words, you give TXA to 67 people, and that's going to prevent one bad outcome. That's really good. That's actually very good. The number needed to treat in the MATTERS trial, was 7. That's even better. So in those really sick combat military casualties in southern Afghanistan, they gave TXA to 7 people, and they were able to determine that prevented 1 death, 1 bad outcome. And that's a really big deal. Depending on what you look at in the literature of number needed to treat, we get excited about things in medicine that have a number needed to treat of 40, 50, 60. To have a number needed to treat of 7, that really gets our attention. So those 2 trials led to the TXC, the Tactical Combat Casualty Care Course, recommendations from kind of the joint military to make it a level 1 recommendation. That's a big deal. That's coming straight from the military. This is a level 1 recommendation. If a casualty is anticipated to need significant blood transfusion, presents with hemorrhagic shock, 1 or more major amputations, penetrating torso trauma, evidence of severe bleeding, they should get TXA. 1 gram as soon as possible, but not later than 3 hours after injury. And we'll talk about those time frames because that's key. As soon as possible, but certainly not after 3 hours from time of injury. And you'll hear me emphasize that a lot. Going even further, the clinical practice guidelines for the joint theater trauma system, the early use of TXA as soon as possible after injury, but ideally not later than 3 hours post-injury, should strongly be considered for any patient requiring blood products in the treatment of combat-related hemorrhage, and is most strongly advocated in patients judged likely to require massive transfusion. That is straight out of the military clinical practice guidelines. So side effects, right? I just told you, great evidence, big trials, lots of patients. World Health Organization says do it. TCCC says do it. Clinical practice guidelines from the military says do it. Every time we add a new medication, every time we do something for our patients, we have to ask, what's the side effect? What are the potential downsides? How could this maybe hurt somebody? Very legitimate and very appropriate questions. So if the goal or the design of TXA is to stop clot breakdown, the thought would be, the major side effect would be, what if patients started to have too much clot? They started getting clots in the legs, they started getting clots in the heart attacks, they started having pulmonary embolisms, and so that was the question. They looked at these, CRASH 2, that first big trial, 20,000 patients. They found no increased risk of thromboembolic events or complications, meaning no increased risk of clots, pulmonary embolisms, etc. Now, in the MATTERS 2 trial, they found a little bit different. There was a statistically significant increase in DVT, which is deep vein thrombosis. Those are clots in kind of the deep veins, typically in the legs. It can be in the arms, more typically in the legs. And PE, pulmonary embolism, so that clot in the leg breaks off, goes to the lung. However, it was statistically significant, so that raised some red flags. But if you really boil it down, if you really look at the numbers, it's a very small number of patients. And if you correct for the severity of injury, there was no association of TXA with increased risk of DVT or PE. So in other words, what we know about sick trauma patients is that they lie in bed, they're on a ventilator, they don't get up, they don't move around. They're already at risk from getting DVTs and pulmonary embolisms. That's a very common thing to happen. And so if you correct for kind of how severely injured they were, TXA didn't really cause there to be any more clotting than we would essentially normally expect. And so that's important to look at. So next question, right? Everybody who's in charge of the purchasing and cost of healthcare, EMS is no different. We live in a pricey, and we owe it to our organization, to the citizens we serve, to our taxpayers to be cost efficient. And so here are just some costs. I had Steve Hammonds at Coleraine Township do a little bit of price. He does our purchasing, and he just kind of looked at, and generally at our suppliers and costs of medications. And so your supplier may be a little different, but I've looked at a couple of different places, and these are relatively what we're paying. You know, amp of 6 milligrams of adenosine, $7. Epi, cardiac epi, $4. Milligram of glucagon, $90. 2 milligrams of Narcan, $17. So how many milligrams of Narcan are we giving, on any given patient, right? I mean, I feel like most patients get 2. They might get another 2. They're, 4-ish, maybe sometimes more. But $34 for, a heroin overdose, potentially $90 for, hypoglycemia. We're looking at a 1 gram vial of TXA, right around the $40 mark. That's roughly kind of where it is ebbed and flowed over the last couple of months. I've seen prices of $35. I've seen prices of $45 for a gram. And a gram is our dose. That's per dose per patient. So if you do the number needed to treat, go back to the 67 and that 7, how much do we need to spend to prevent a bad outcome? That's an important question. Roughly $259 up to about $2,500 to prevent a bad outcome. If you think about kind of the cost of health care, the things that we do for the critically injured, badly hurt trauma patient, this is not the slip and the fall in the bathroom. This is the I just fell 20 feet off a ladder. That's pretty reasonable. That's very good. So it's cost effective, and that's a benefit of, again, it being an older medication. This is not something kind of new and hot off the press out of a laboratory. It's an old medication. It's been around a while, and it's affordable. So the question is, I've said this, we give TXA in the operating rooms at University of Cincinnati. We give it in the surgical ICUs. We certainly give it in the emergency department. We give it on air care and mobile care. There's a variety of other helicopters now that are doing it as well. So the question is if we give it to the patients in the hospital and you give it to them in a helicopter, why do I need to carry it on my truck, right? That's a legitimate question. That's a question you should ask. So, and there's an answer for that. The answer comes out of a kind of a sub-study done out of CRASH 2. This is going back to that first big trial I showed you, 20,000 patients, 40 countries. And what they did was they looked at when exactly should we be giving TXA? And what they found was that there was strong evidence that the effect of TXA on death due to bleeding varied according to the time from injury to treatment. In other words, time 0 is the car has crashed, and there is significant benefit the sooner we give them medication, that TXA, from time 0. What they found was early treatment, less than 1 hour from injury, significantly reduced the risk of death due to bleeding events in the TXA group compared to the placebo group. Patients between 1 and 3 hours also benefited, but not as much. And then outside of 3 hours, there was potential for harm. And so that's where we get into kind of the time. So we know within an hour of injury, that's the best. 1 to 3 hours is good, and we want that. Greater than 3 hours, that's when we're going to stop. We're not giving it to patients greater than 3 hours out from injury. So they concluded TXA should be given as early as possible to bleeding trauma patients. For trauma patients admitted late after injury, TXA is less effective and could be harmful. So earlier is better. That's why this medication should be on your trucks. This is just a kind of a typical mission timeline. I use kind of Corrine Township because that's where I do most of my ride time. Let's say rollover MVC, Corrine Ave and West Kemper, roughly 22 miles or so. That's time 0. 3 minutes, cell phone call from a passing car. Says, hey, this car's rolled over. 911 dispatch of police, fire, and EMS, another 3 minutes. Arrival of ALS services, 8 minutes, give or take, plus or minus. Secure the scene, patient assessment, another 5 minutes. Extrication and packaging, 5 minutes. That's probably, on the low side, but, just ballparking. Load them into the medic unit, another 3 minutes. IV, control hemorrhage, apply oxygen, 4 minutes. Roughly transport, 20 minutes to UC. Unload them, unhook everything, get them into the SRU. Patient report, 1 minute. So these are just a kind of a ballpark timeline. And you may say for your agency, well, we're much closer than that, or we're much faster, or whatnot. But that is some roughly, for a county EMS agency, this is a pretty typical average timeline for a critically ill trauma patient. We are already at time 55 minutes. Roughly. Now, you could easily say, we're closer, so that would help things out a little bit. But certainly there are other factors that make it much longer to get the patient to the shock resuscitation unit, SRU at UC. Longer EMS response times, longer extrication time. I mean, in that scenario, it was only 5 minutes. What if it's 10, 15, 20 minutes? Multiple patients. What if you've got, a van full of 4 or 5 people? Multiple medic units, kind of the normal, kind of organized chaos that occurs at those scenes. Patient condition, what if they need a bunch of other interventions? They need to be intubated. You need to bind their pelvis. You need to apply, tourniquets, etc. All of these things, patient condition can certainly delay getting a patient, rightfully so, to the SRU. What about closest facility transports? What about, outside hospitals that don't have TXA? What about that unstable airway that you take to a smaller emergency department that doesn't have TXA yet, and then they get transferred? Those patients are always, not always, but frequently outside of the 3-hour mark to get TXA. What about weather? On a day like this, it took me 20 minutes longer than it typically does for me to get out to this part of the county from my home just because it's pouring rain. Traffic is certainly obviously. So there are big factors that prevent our delay of getting patients to the SRU, particularly within that hour to get TXA. And then I've worked in the SRU for 4 years at university. I did my residency there. It's a phenomenal place. It is where I would want to be without question if I was critically injured in a trauma. But at the end of the day, there are delays in the hospital. There are delays in the system. You got to get labs. You got to get CT scans. You got to get X-rays. You got to, other medications. So there are delays even in the hospital of getting TXA. It's not like a patient rolls into SRU and there's this kind of golden vial of TXA being ready to be injected into their vein, right? That just doesn't happen. So knowing that EMS is such a critical part of the continuum of these patients, you are the professionals that are caring for these patients in that first hour. That's why this makes sense. So it's being done. Helicopters were really the first kind of pre-hospital organizations to be doing it. Air Care's on there. A variety of big name programs all over the country are actively doing this and more every day. I got phone calls from a state in the South that wants to do it. I mean, it's rapidly expanding, and that's a good thing. What about on the ground side? I told you Dr. Jeffrey Goodlow in the Tulsa and Oklahoma City were kind of the first. He's really been the champion of this. They really are the ones that put out kind of the first protocol for this. It is in Ohio, so the first ground EMS agency to give TXA was just kind of out in the Columbus area. This was in the fall of last year, so going on almost about a year ago was the first administration of TXA by ground EMS. I believe this was, Newark Fire was the first department. This is a woman, I believe, fell off her bike and was hypotensive on the field, or in the field, got a gram of TXA, I believe, on the day that the fire department rolled out the medication. So, and she pictured here doing well. So it is in Ohio. It is in ground EMS agencies. It's rapidly spreading, and it's coming to Southwest Ohio. This is just an example of the Oklahoma City Tulsa protocol. We don't need to belabor this. I just show that to show you that there is, our protocol reflects that. It mirrors kind of what's being done around the country. So a new protocol in 2015, and this is where we get down to kind of the nuts and bolts of how we're going to do it, what we need to do, how it's going to work in real time. And so I hope I've convinced you at this point in the first, 30 minutes of this that this is a good thing, that the evidence supports it, that EMS plays a critical role in administration of this medication. So in typical kind of Southwest Ohio protocol, it's already in that format. This is kind of typical scheduled protocols will come up for review by everybody kind of October. We'll make some last minute adjustments at the committee level or editing, etc., and then the protocols go live in January. This will be S506, so we specifically designed this protocol because it's a new med, because it's something new to the region. It's its own protocol. Maybe in future years when we're comfortable, maybe it'll be wrapped into kind of hemorrhagic shock or something right now. But for the purposes of kind of quick reference, easy reference in the field, it's its own protocol. Inclusion criteria, very simple. Evidence of significant blunt or penetrating trauma based on their history or their physical exam. I've just put some examples up there. So those are examples of kind of trauma stat criteria at UCMC. So somebody's ejected, rollover MVC, fall greater than 20 feet, penetrating injury essentially to the box, pedestrian struck. So they have evidence of significant injury by history or physical exam. They're greater than 16 years old. So right now, this is an adult medication only. There is work being done on the pediatric side. I think in the future we will be doing this for pediatrics, but currently at the time this is an adult medication only. The patient needs to be going to an adult trauma facility. Age greater than 16, evidence of concern for severe internal or external hemorrhage. So bleeding requiring a tourniquet. Maybe their pelvis is unstable. Maybe they've got bilateral femur fractures, flail chest. So significant injury, you have objective concern based on their physical exam that they've got severe internal or external hemorrhage, they're an adult patient, and they have hemodynamic instability. So systolic pressure less than 90 or less than 100 if greater than 55. So in your mind, blood pressure less than 90, if they're an older patient, less than 100. Sustained is 2 independent pressures. So what we put that in there is because you know as well as I do that sometimes you throw the life pack monitor on there, or it's not fitting right, or it's over a jacket or something like that, and you get one blood pressure that's 80 and everything else is 140. We want to make sure 2 different blood pressures of, yes, this is less than 90, they are hypotensive, and while you've got them on the monitor, their heart rate's greater than 110. You have those markers of instability, you have a sick mechanism of injury, sick trauma patient, bad mechanism of injury, and you know the injury is less than 3 hours. How do we know? Typically, most of the things we do in EMS, we know, car accident happens, gunshot wound happens, somebody calls 911, it's not a factor. I bring this up only because what about the patient who's found in a car, hypotensive, it's 5 in the morning, and we don't know when they drove off the side of the road. Engine block's cold, it's covered in snow, we're unsure. Maybe it happened an hour ago, maybe it happened 6 hours ago. We have to know that time of injury was less than 3 hours. And that's a big window, that's a very big window, but we have to know. So questions on that, that's the inclusion criteria. Significant injury, adult patient, hemodynamically unstable, less than 3 hours. Okay? And there's a checklist that goes with this that I'll show you. So super important, this is the big kind of take-home message, or one of them. Significant trauma, adult patient, hemodynamic instability, less than 3 hours, gets TXA. So kind of going on with the protocol, manage the airway, administer oxygen, control hemorrhage, do the normal things that you would normally do, that you do day in and day out and do well for your sick trauma patients. If the patient meets the inclusion criteria, they get 1 gram of TXA in 100 mLs of normal saline or lactated ringers infused over 10 minutes. Now, kind of roughly, there are, military has looked at kind of pushing it faster than that or giving it as IV push. The biggest side effect when you IV push TXA is hypotension. So they're already hypotensive. We want to avoid, just bolusing them, somewhere over 10 minutes, being reasonable. If it goes in over 12 minutes, that's okay. It goes over, 9 minutes, 8 minutes, that's okay too. We just are trying to avoid the draw it up and push it in, like a code situation. That's not what we want. Use a dedicated IV or IO. This is just as good in the tibia IO or the humeral IO as it is in a 18 gauge in the AC. It can go in either way. Do not administer in the same IV or IO as blood products, factor 7, or penicillin. And I put that in, that's not really for fire-based EMS so much as maybe you're doing a critical care transport, or you're a paramedic that works for another agency on your off days. This is a medication that does not go in the same IV or IO line as getting blood products. So if you work in a situation where that's never the case, great. But if you do, just tuck that in the back of your mind. Really cannot go in with blood products or factor 7 or penicillin. During the radio report, it's absolutely key that you let everybody know that you gave TXA. So being one of the docs who, holds the telemetry phone for EMS in the region, a radio report for a patient that's getting TXA is something like this. This is medic whatever. I am en route with a 5-minute ETA with a rollover MVC that has gotten TXA. That tells me right away that everything else after that you're going to tell me, that this guy was sick enough to get TXA, and that is an immediate trauma stat for us. That we are activating all the trauma resources, OR, lab, X-ray, etc. That is somebody getting TXA pre-hospital. That is something that we want to know in that first, 10 words of a radio report down to UC. When you're transferring care, completing your run report, PCR, etc., please note the time of injury. We want to know best estimate. Look at the pager, look at your CAD system, kind of however you estimate time for your agency and your region. We want to know your best estimate. It doesn't have to be down to the second, but kind of a best estimate of time of injury. That helps us know for redosing TXA in the hospital, etc. And then what time you gave TXA. So think of it like a tourniquet. You put a tourniquet on, you note the time, same way with TXA. We want to know exactly when you gave that bolus. It helps us with kind of what we're going to do moving forward with TXA. So there are some exclusion criteria. There are some things that would exclude us from a patient getting TXA. First and foremost, and this is probably one of the most important ones, is less than 16 years old that don't get TXA. They're 14 and they're going to children's. They do not get TXA right now, this year, this protocol. Maybe that will change. We'll see as kind of more science and research is done. Time elapsed from the initial injury is unknown or known to be greater than 3 hours. So if you roll up on a scene and you have no idea when this car went off the side of the road, they're a sick trauma patient, but you really honestly can't tell, then they don't get TXA. We have lab tests and other things that we can do in the hospital to kind of help us figure out if they need it or not. But at least for kind of pre-hospital administration, we're not going to give it. Patients with clear contraindications for antifibrinolytic agents, so somebody who maybe has a clotting disorder or something in the past. This is information that it has to be in the protocol. It's information that we have to tell and we have to talk about. But in reality, of a very sick, maybe unresponsive, hypotensive trauma patient, you may not be able to find out that information. And that's okay. We do the best that we can in the situation that we are in with the information that we have, and we do the right thing for the patient based on what we know. And that's understandable. Should not be given to isolated head injury. Okay, so let's say it's a single gunshot wound to the head, hypotensive. Right now, currently, we don't give it for just isolated head injury. You got to think that there's some other injury somewhere else. That may change. There is research actively being done in this region on TXA and head injuries, but for right now, we don't give it for just a head injury. It's got to be injury somewhere else. TXA should not be given to patients who will receive PCCs, factor 7. This is really more for kind of the critical care transport. If you're a fire agency or an EMS agency that's doing some critical care transport, some hospital transfers, that's important for you to take note of. TXA should not be given to women who are known or suspected to be pregnant with a fetus of viable gestational age. So we don't know exactly what the effect is of TXA on the placenta. We don't know exactly what the effect is there. And so this comes from the UCMC Division of Trauma. I think it's very reasonable. If you have a woman with a very large, gravid, abdomen, you think, man, her top of her, uterus and the baby is, right around the umbilicus, right around the belly button. We typically think about that as being viable. We shouldn't give TXA right then and there in the pre-hospital setting. We should wait. Now, if you have somebody who's hypotensive, very sick, trauma patient, and they're 8 weeks pregnant, do give it. Because that's a baby that that baby, if delivered, is not going to survive. And so in that situation, what is best for baby is what's best for mom. And if that's TXA, then that's TXA. So if it's not a viable pregnancy, first trimester, 10, 12, 14 weeks, 18 weeks, it's not a baby that if it were delivered right now would have a real strong chance of survival, then we should give TXA. If it's a baby that's 32, 34, 36 weeks, hold off, and we'll figure things out in the trauma bay. Previous allergic to TXA, I don't know how you would know that unless you've gotten TXA previously, in which case that's a very unlucky individual. But if you've had a previous allergic reaction to TXA, they should not get TXA. And then medical control discretion. So at all times, always, there is 24/7 an emergency physician at UCMC who wants to be engaged in these decision making, who is going to be the person taking care of this patient. They are going to be the doc that you're talking to real time in the SRU. Call them. They want to be involved in helping make these decisions if there's any question whatsoever. But this is not something that you have to call medical control for. If you've got the indications and you're super busy, the last thing we want for you to do is be making a phone call to get permission to do this. That is not the protocol. The protocol is you've got indications, you give it. If you have a question or something's kind of on the line or whatnot, we're there to help. That's all. Here's just kind of some basic information that will be included in the protocol. Just we're a teaching protocol, so a lot of this information is already covered in this hour. Here's a checklist that's going to be included with the protocols. My suggestion, what I think probably works reasonably, is probably reasonable for this checklist, is when you get your 1 gram vial, EMS officers, lieutenants, captains, however your organization is structured, print these out, kind of small on a piece of paper and wrap it around the vial. That's what we do with a lot of medications that are kind of new. Print this out. That way when you go to pull out the TXA, it's 3 in the morning, you just woke up, it's groggy, the lighting's poor, it's cold, wet, rainy. You've got a memory aid to make sure we're doing the right thing at the right time for the right patient. Age greater than 16, check. Evidence of significant trauma, check. I'm concerned they have severe internal bleeding, check. They're hypotensive, they're tachycardic, and the injury just happened, check, check, check. And it reminds you how to give it. Okay? So that checklist is there. I am a firm believer in using checklists. We should be using more checklists, I think, in all of medicine and EMS particularly. So it's there to be used. It's there to be helpful. It's not a requirement. There's nobody going to be at UCMC waiting to get your checklist. There's no policing of that. This is just to be helpful. Here's how you give it. It comes in a 100 milligrams per ml. It's a 10 ml ampule, so it's one bottle is 1 gram. That's the dose. There is no weight calculations. Everybody gets 1 gram who's getting this. Filter needle alcohol swab. You draw it up. You put it into a 100 ml normal saline bag, and you run it over 10 minutes. If you can, use a dedicated IV/IO line if possible, and that's really more for the if you're doing a critical care transport or something like that, and there's other medications going on, there's other things being infused, trying to have TXA in its own IV. For typical 911-based EMS, what we do most frequently in the county and for the city, this won't be an issue. So take-home points. Adult, significant trauma, hemodynamically unstable, time of injury less than 3 hours, gets 1 gram, always 1 gram, that's it, 1 gram. In 100 ml normal saline or lactated ringers over 10 minutes. So more research is ongoing. Like I said before, there's a variety of different trials and studies going on. There's more information that will be coming. Questions that have been raised, we're giving it for a trauma patient. Can we give it for a massive GI bleed? Can we give it for a ruptured, aortic aneurysm? Right now, for this protocol, it's trauma only because that's the literature that we have to stand on. In the future, who knows? This, I think, medication is ripe for expanding in other bleeding patients. You may have heard a little bit, and this is kind of recent, of UC doing a TXA trial. There's been a variety of attendings. Dr. Jason McMullen, Dr. Bryce Robinson, kind of on the news talking about this. Patients may be asking about this. Us giving TXA for this protocol is entirely different, separate, and has nothing to do with what they're doing. And so I only throw that up there just to answer that question. I've already gotten that a couple of times. They are specifically doing a research trial for TXA in traumatic brain injury. That has nothing to do with our Southwest Ohio protocol at all. So that just to answer that right now. So here's what we know. Decrease in all-cause mortality, greatest benefit if they're in severe shock. Early administration is the key. Administration when you are caring for the patient in that first hour is the best, and we shouldn't give it if the injury is greater than 3 hours. Jim's April 2013, Dr. Goodlow out of Tulsa and Oklahoma City did a great kind of review on this and talked a lot about their experience. I highly recommend that as just an additional source of reference and resource. There's a bunch of resources there in the protocol that you can look at if you want to know more and see kind of where we're getting this information. And at that point, take any questions. Any questions at all?